NSG-321, Nursing Practice Theory. And I am joined, this is Stephanie Bondison. I am Director of Academic Excellence for the College of Nursing and Healthcare Professions at Grand Canyon University. And joining me is Tammy Druitt, one of our faculty members who teaches several sections of NSG-321 this semester. And initially I want to just go over the reason for these content clinics and some of the history behind it, and then Professor Druitt will take over and she will be going over the content for Exam 1, content review. So first of all, the content clinics were started in this fashion in spring 2015, and we grew the content clinic offerings so that we increased our offerings over the summer 2015, and now for fall we have content clinics for all theory courses within the College of Nursing and Healthcare Professions curriculum. So that is a little bit of what we do, and why we're doing this is for various reasons. We had quite a bit of student feedback that requesting additional support just due to the nature of the nursing content being very rigorous and content rich. And so, you know, these support sessions are another additional way, an additional touch point for you in your courses outside of the class itself, where you can get additional help and have an opportunity to either rehear some of the information that you learned, or to maybe hear it a little bit differently so that you can maybe absorb the content in a way that will be helpful to you throughout your program. So the purpose of tonight's content clinic is specifically to focus on Exam 1 topics. And if you are attending this session live, please use the chat feature on the webinar, and you can submit your questions regarding the content that's being covered, or an additional question that maybe is on your mind that we are not covering currently that we can try to answer for you before the session is over. So this session will last approximately 50 minutes from start to finish, and but if there aren't a lot of questions, we may end up finishing early. So I would like to turn it over now to Professor Druitt, and she's going to be the one to cover the specific content for you for the content clinic.
Hello, I'm just going to review the topics that are going to be covered in Exam 1. There's quite a bit of information, so I just want to help you be able to focus in on what is really important. The first topic is homeostasis, stress, and adaptation. The biggest thing that we're talking about is how does the body work to regulate itself when there's imbalances, and how does each patient deal with the stress of illness or whatever else is going on in their condition. A lot of patients are really good at coping, and a lot of patients are not. And when they are not good at coping, it adds extra stress to the body, and you can have both physical and psychological effects from that. We're also going to talk about fluid regulation, mostly fluid volume overload and fluid volume deficit. Topics that are covered in that, basically signs and symptoms, what does it look like when someone has too much fluid, and what kinds of steps are nursing interventions to help control that. Same exact thing when we're talking about fluid volume deficit. What mechanisms are in place that the body tries to go through, and then again, what nursing interventions. Sometimes we have patients, for example, that are in ICU and they're septic, and we really pump these patients full of fluid, and we can actually put them in fluid volume overload. So we have to be really careful, and we are often in charge of keeping that balance. Hypovolemia is a shock condition. Basically, the body doesn't have enough fluids, whether it be blood or just body fluids. People can be hypovolemic from trauma and they lose a lot of blood, but they can also become hypovolemic if, let's say, you eat bad Chinese food and you're vomiting and have diarrhea. You can become dehydrated quickly, and it can lead to this condition as well. Another topic is genomics or genomics. If you're going to be a nurse that's going to work with genetics, this is a great topic for you. As far as everyday nursing, we don't get into a whole lot of details of DNA and that type of stuff. Hopefully you remember a little bit of it from your A&P classes. But certain diseases like Huntington's disease is a genetic disease, and you will be taking care of patients that have this disease. One of the biggest questions that families and patients ask nursing is, when it's a genetic disease, what is the chance that if they become pregnant or they are pregnant, that this will be passed on to their children? No matter what the condition is, it's always going to be a 50-50 chance. It's either going to be yes or no. If they want more specific details, then that's when they're going to have to follow up with a doctor that specializes in that. Okay, we can go to the next slide. Fluid and electrolyte imbalances are probably the biggest topic for this section, because this happens all the way across the board for the rest of your nursing career especially. You need to know your lab values for your main electrolytes. Students often ask me, what do I need to memorize as far as labs? And it is impossible to memorize every single lab that's out there, because there's hundreds of lab tests. But you need to know what the electrolytes are. Mostly potassium, which is 3.5 to 5.2, sodium, which is 135 to 145, calcium usually is 8 to 10, and your magnesium is 1.5 to 2.5. These will sometimes vary slightly depending on the facility that you're at and what their exact lab standards are, but these are the basic lab values, and you do need to know them. In lecture, you will be reviewing each of those 4 main electrolytes, what happens to patients when they don't have enough or when they have too little. Well, that's the same thing. Or when they have too much, when their levels get too high. And then what do you do about it? Key points to remember is potassium is going to have the biggest effect on the heart, especially if your potassium levels are low. You're going to start seeing ectopy or extra beats on your patient's EKG. When potassium gets too high, it can affect your neurological system, and your patients will have confusion. When your potassium is low, what do? We replace it. Number 1 rule of nursing, never, ever, ever, ever are you going to push potassium. Potassium is given either orally or IV, but it has to be given slow. If you have a peripheral IV, meaning the IVs that you guys are starting in labs, those are all peripheral IVs, you have to give it slow because it can burn the vein. If your patient's in ICU and has a central line or a PICC line, you're able to run it a little bit faster. If your patient has a potassium that is way too high, we try to help the body get rid of it. We usually give a medication called K-exolate, which basically binds to the potassium, and the patient poops it out. Some doctors want to use another method in which we give glucagon and insulin and try to push the potassium that's in the bloodstream back into the cells. But if those 2 things don't work and your patient's potassium is still quite high, that patient may have to have dialysis. If you have low sodium, you're going to see neurological changes. We want to replace that sodium, but we don't want to replace it too fast. Usually high sodium, those patients are going to be on a fluid restriction and a salt restriction, just like all your cardiac patients are going to be. Calcium, you're going to see lower levels more than higher levels. For low levels of calcium, we're giving calcium replacements. Magnesium, that can be given in oral form or IV. And we'll go over more of those in lectures, but those are the basic key points of those. Hematological disorders, again, you need to know your labs for your hemoglobin and hematocrit. It does differ slightly between men and women. You need to know that if your patient has a hemoglobin of 6, whether they are male or female, that is not good, and they need a blood transfusion. Usually, in most cases, we usually don't transfuse blood unless your hemoglobin is less than 8. And again, it depends on the situation. If your patient has a GI bleed and is bleeding a lot, they may replace it higher than 8. Albumin. Albumin is a protein that's made in your liver. What it does is it helps keep fluid where it needs to be. If you have, for instance, a patient that is in fluid overload, some of that fluid doesn't have enough room, so it leaks into the tissues, and it's called third spacing. Albumin is really good at helping drawing that extra fluid back to where it needs to go. Sickle cell anemia and hemophilia are the biggest hematological disorders that we talk about. Sickle cell anemia is, let's see, hang on, I'm trying to figure out how to explain it. Basically, you have round red blood cells, and in sickle cell, they look like saucers. And the importance of that is that your red blood cells is what carries your oxygen. So you have these nice round blood cells, and the oxygen attaches to it and floats around your body. And a sickle cell crisis, when those are concave and kind of flat, there's not enough room for the oxygen to stick to that. So these patients are in a crisis because they become short of breath rather quickly. All the patients that we're going to talk about this semester, we're always proactive in getting your patients up out of bed, getting them as active as we possibly can. Sickle cell patients are one patient that during a crisis we do not get them out of bed because that causes them to use more oxygen and they're not able to have a good supply of that. Hemophilia is kind of rare, but your book talks about it quite a bit, and you don't really hear about this as much, but what's happening is that your blood doesn't clot efficiently, and a cut could really make someone bleed an awful lot and send them into hypovolemic shock. It is uncurable, and we can't always do a whole lot for these people, but remember that cold compresses can help. We don't want to give them aspirin or anything like that that can thin the blood more, but by applying a cold compress, we can help slow the bleeding down. Okay, next slide, please. Immune disorders, you need to know the difference between passive and active immunity. This is when we're talking about flu shots. And the biggest thing we're talking about is HIV and AIDS. So when AIDS first came onto the scene, there are a lot of nurses that were afraid to take care of patients that had it. But we always use universal precautions with each and every patient, meaning hand washing, gloves, never touch any body fluids without gloves on. You never know what a person may have, and you need to protect yourself. The biggest thing to remember here is that somebody can be HIV positive for their entire life, and they will never convert to the AIDS virus. What happens is you get these opportunistic infections, and that's what converts it from HIV to AIDS. These patients are a lot of times on antiretroviral therapy, and sometimes it's 3 or 4 medications. There's a lot of education involved with these patients because we really need them to be compliant. Another section that we're talking about is going to be surgery. Pre-op, which is before, during surgery, and post-op. You're going to have clinical projects to do in your clinical groups where you're going to take core measures, and core measures have been established for hospitals that they have to meet certain criteria with certain diagnoses. And for surgery, it's called SCIP, which is a Surgical Care Improvement Project, which means everybody that has surgery has to have informed consent. This consent is done after the doctor talks to the patient. The patient needs to understand the surgery that they're having, the risk, and the benefit. If the patient has more questions than you can answer about the surgery, then you call that surgeon back and you tell him that the patient has questions. They have to understand the surgery that is going to be performed, and it is actually the surgeon's responsibility to do that. You may have the patient sign the consent, but that is after they have had all their questions answered by the surgeon. We usually do pre-op checklists. Patients have to have a full history and physical on the chart. We do baseline labs. We do baseline EKGs. We need to know all the medications, over-the-counter and herbal medications that the patients are taking prior to go to surgery. The pre-op checklist also includes the exact surgery site. And there has been several instances, oh my gosh, didn't say that word, in which the surgery was performed on the wrong body parts, meaning amputation of the left leg became an amputation of the right leg. And you can look online and find numerous cases like this. So we have to make sure that what we are going to operate on is clearly identified, meaning the patient, the surgeon, and the anesthesiologist are all going to actually write on the physical patient their initials to confirm that this is the site that we are doing. Informed consent is important. I'm sure most of you have heard about the Tuskegee Airmen, where the government did these experiments on people without their knowledge, and quite a few people died. It was actually a horrific experiment. And due to that and other things like the Nuremberg trials, we have to have informed consent. The patient has to understand. If your patient has a language barrier, you have to get an interpreter. And housekeeping does not count as an interpreter. It has to be a certified interpreter in order to have informed consent. We'll also discuss the role of the scrub nurse, what happens in surgery, what they are responsible for, and the biggest thing is post-op care. Patients come out of surgery, what is the most important thing that we monitor? ABCs. We need to make sure that they are breathing after surgery. We put, I can't even say that word, SCDs, sequential compression devices, which help keep the blood circulating so patients don't get blood clots after surgery. The biggest risk for a patient after surgery is pneumonia. We need to get these patients up and walking as soon as possible. Patients that have open heart surgery have had their chest sawed in half, rewired shut. They have a central line. They have chest tubes. If they got veins from their legs, they have sutures up and down both legs. They have a tube sticking pretty much out of everything. And 4 hours after the patients are off the breathing machine, they're sitting at the bedside. If you have open heart surgery in the morning, you are walking the unit at night before you go to bed. So if an open heart patient gets up and moves, everybody else needs to get up and move as well. Education is very important in the post-op area. Cough and deep breathing, using the TED hose, and getting up and moving. All of those are included in your nursing intervention. Maybe I'm going too fast, Stephanie. Okay, cancer patients. As we go through each body system, we'll go into more detail about cancer. But basically, there are 4 treatments for cancer. They have radiation and or chemotherapy, they have surgery, or we do nothing. Cancer care is basically the same no matter what kind of cancer you have. When we get into those other body systems, it'll be more specific. But basically, we're trying to keep them as comfortable as possible, as pain-free as possible, and trying to keep their nausea under control if they're having radiation and chemotherapy. Usually cancer is diagnosed, we do a CAT scan, we may find something, or an MRI, and it is confirmed with a biopsy. Sometimes these patients can also be on neutropenic precautions where their white blood cell counts are so low that they are really susceptible to getting sick. and this is a case in where we're not protecting ourselves from the patient, like with MRSA or C. diff, but we are actually protecting the patient from us. The biggest thing that you're going to have to remember out of your med-surg nursing is how to prioritize care. Every exam is going to have questions about prioritizing care. You have 4 patients. You need to choose which patient you need to see first. The same thing on the NCLEX. They want to know that you can prioritize care. The biggest thing is always ABCs, airway, breathing, circulation. Does everybody have an airway? Is everybody breathing? Is everybody circulating? When we get into ortho, a lot of students forget the C part, and if you have a patient that perhaps had an open fracture and had leg surgery, and you're not checking pulses on their feet, that's a circulation problem, and that patient can lose their leg if you're not doing a good assessment. So circulation is very important. Next to ABCs is safety. We have to keep our patients safe. Safety can be as simple as you went in and took care of a patient, maybe you changed them and you lowered the bed rail, making sure that that bed rail is up before you step out of the room. Patients that want to get out of bed are usually patients you don't want to get out of bed. Dementia patients, confused patients, these patients always want to get out of bed, and that's what makes them unsafe. So when you're trying to prioritize care and you have a patient that everybody's airway, breathing, and circulating, but there's a patient that is confused. Maybe they're confused because their sodium is low. Maybe they're confused because they had a stroke. Maybe they're confused because their potassium is so high. These patients will be unsafe, so they become a priority. After those first 2, you have to look at everything else, and as bad as this sounds, when you have to pick 1 out of 4 patients to see first, if you do nothing, what patient will die first if you do nothing? Because that's your priority patient. Anything that's new, anything that says new onset, or any changes in your patient condition become a priority. Then after that, we look at vital signs, and we'll talk about that more in lecture, what we consider to be appropriate range for vital signs, and then your lab results. And it's really going to require you to think about who you're going to see first. And you will always see these questions throughout your nursing career. And then when you become a nurse, you're on a med-surg unit, you have 6 patients. How do you know who to see first? So you have to start prioritizing now. Okay, we can go to the next slide. Or is that it? Oh. See, look, I talked way too fast. We're going to have content clinics. There's one today. There's one September 14th, September 28th, October 12th, October 26th, and November 9th. They're going to be about the same concepts, whatever we're talking about to prepare for the next exam. You do have an opportunity to join us live and ask questions, and I'll try to answer as many questions as I can get through. If you have a question prior to the session, let's say noon, before we're going to do a content clinic, please email me any questions you may have, and I can address those during the content clinic as well. We're going to do additional content clinics on Thursday. We're going to do one next week, September 10th, and then tentatively the 24th, October 8th, October 22nd, that's my birthday, and Thursday, November 5th. So this is designed for you. If you have questions or you're not understanding specific topics that we are talking about, this is a good point for you to be able to ask for clarification.
All right, so we do have an attendee on the line. I don't know if there are any questions that we can answer in addition to what has already been covered. So if you have a question, please feel free to submit it as a chat, and I will read the question and share that with our instructor, Professor Druitt. I do know that from prior content clinics we have had in other courses this semester, one of the questions is, what can I do to be successful in this course? Maybe you can answer that one.
Nursing is a unique profession in which what determines if you get an RN behind your name is one exam, and that is the NCLEX exam. It doesn't always look at how well you do in clinical, how well you interact with other nurses, other members of the interdisciplinary team, and your patients. It's all based on an exam. Simple, well, not simple, but things to remember about NCLEX. Number one, NCLEX testing, it is a perfect world. You have enough staff, your doctor is at your beck and call, you call respiratory, they're right there, you have all the supplies that you need in that NCLEX setting. In the NCLEX world, you can do one thing at a time, which is why prioritization is so important. You may have two orders. You're going to give a septic patient an antibiotic and Tylenol because they have a fever. Which one of those is more important? They're equally important, but you can only give one at a time. So we're going to actually start the antibiotic first because we want to get that circulating through the system as soon as possible. The easiest way to practice is to get some type of NCLEX study book. There's a ton of them out there. I find that Saunders is really one of the best ones. You don't have to spend a lot of money. You can find a used one or even not the latest edition. But what they do is they break down the body just like we're going through it, and they have practice questions. There are always two right answers for every NCLEX question. Your job is to be able to figure out which one of those two is actually the best answer. Sometimes you understand the content and have difficulty picking one or the other. By doing NCLEX reviews, it'll help you study for whatever topic we are working on, but it'll help you get better at choosing which answer is the better of the two. Because most of those, they ask a question and they give you rationale as to why that one out of the four of them is the better answer. And the more you practice answering NCLEX questions, the better you're going to be at answering them. You're in semester 2, you have 3 more semesters. I suggest you start practicing NCLEX style questions now. We're going to start talking about oxygenation, cardiac, pulmonary, for the next exam. You can start looking at those questions as we're going through that material and so on. When you get to OB and pediatrics, there's questions in NCLEX about those subjects. And when you get to your last level, you should hopefully get better at answering the questions. It's really hard a lot of times to try to pick which one is the better answer. Students are awesome at narrowing it down to 2, but you just need to fine-tune how you think through the nursing process to be able to pick that one that is actually the best answer. And the more you practice, I guarantee you, the better that you're going to be at that.
Excellent, thank you. All right, another question is, do you recommend studying in groups?
Well, that really depends on how you study. When I was in nursing school, there'd be a group of us, we'd go grab lunch and we'd kind of bounce ideas back and forth. And that works for some people, but some people it doesn't. You just have to figure out which works best for you. The thing about nursing is that it's not black and white. The NCLEX, there's 4 answers, half of them are right, and you have to pick one. So sometimes studying in a group, you can kind of bounce the ideas off of each other because everybody thinks a little bit differently, and sometimes that can be really helpful.
All right, thank you. Yes, I think so. All right, then another question would be perhaps the tie-in between the theory and the didactic, the theory and the clinical experiences.
Well, that's a good question. We cover a lot of topics in theory, but every disease process that we talk about, we're going through the nursing process. And what is really going to make you a good nurse is your assessment. And each little disease process that we talk about has their own assessment. Cardiac has their own assessment. Pulmonary has their own specific assessment. But doing that good first assessment is actually going to help you because you'll be able to recognize changes in your patients a lot quicker than if you do a haphazard assessment. You should know your patient pretty well from doing that first assessment, and you can pick up subtle changes. Once, you may not always see, like these topics, you may not see hemophilia, you may not see sickle cell, but you're going to see cancer patients, and you know that you still have to do a good head-to-toe assessment. What is a priority for a cancer patient? It's going to be pain because cancer hurts. So pain management is a big thing that you're going to really look for. Patients that are on chemotherapy or radiation are sick to their stomach. They're nauseated. So what can you do about those? So there will be some things in lecture that you may never see, like when we talk about Guillain-Barré, you may never see that in your nursing career. I've seen it twice. But everything else that we really talk about, you will see in clinicals. And you may not see it right away, but you will see it in how we talk about our assessment. I'm going to do a concept map for all the big disease processes. The concept map is what you have to do when you do your clinical paperwork, and that maps out your whole plan of care. It talks about your assessment. It talks about these are the signs and symptoms that the patient has. How do I know that the cough they have is a cough because they smoked? Is it a cough because they have asthma? Is it a cough because they have COPD? Or is it a cough because they have pneumonia? What kinds of questions do we ask, and how do we figure out what that cough really is? We do an assessment, we do labs, we do x-rays, we get our diagnosis, and then we don't order stuff, but we can anticipate what the orders are going to be, and then we follow those orders. How do you know that what you're doing for your patient works? You reassess them. Assessment, reassessment. Assessment, do something, reassessment. Over and over and over. That's the whole nursing process. And you will repeat that. And you'll be able to eventually put the pieces together a lot easier as you learn about the material as we go through it. But it's always going to be that nursing process. Here's my assessment. This is what my patient is saying they have going on. We're doing these labs, x-rays. If they get a diagnosis, this is what we're going to do, and we know our patient is getting better because why? Because we reassess. You guys did, my students were doing trach care, and everybody else, I believe, the first 2 weeks you're doing trach care, where you're suctioning a trach and learning how to do that sterile procedure. You listen to the lungs before you do trach care. You want to know that after you suction the patient, did it help? And how do you know? Your patient's breathing easier, you're going to listen to their lungs. You're reassessing. So those are the key points. Assessment, reassessment, assessment, reassessment, over and over and over. And that will help you tie in what we're talking about in class, because you'll be able to see it when you're actually in clinicals and performing assessments on patients. And during your clinical rotation, you will do a head-to-toe assessment with your clinical instructor at the beginning of your clinical rotations, and then again at the end. And we want to see how you progress through those assessments. I know you had assessments in foundations, and it's always scary. I remember when I did my first head-to-toe assessment with someone sitting there watching me do everything, you're worried that you're going to forget something. But the more you do assessments, the better you're going to be at them. Some students in clinical say, oh, it's boring, I don't have nothing to do. Please don't ever say that. There's always something to do. If your nurse is slow, find another nurse. Or your patient, I guarantee you, if it's an elderly patient especially, and you ask them if you could do another assessment on them, they are going to let you because they love to have the company. And the more you practice that assessment, the better you're going to be at that. That's all I have to say about that.
All right. Thank you. And that we don't have any additional questions. So I would just like to remind the students that you do have several opportunities to provide feedback. First of all, you have the college leadership listed here on the slide. So we have the Dean, Dr. Melanie Logue, the Arizona Director, Sheila Searles, New Mexico Director, Heidi Orrick, Program Manager, Darlene Swint, Director of Academic Excellence is me, Stephanie Bondison. Your Student Services Advisor, you have your faculty members such as Professor Druitt and the other faculty members here in the College of Nursing and Healthcare Professions. And also at the end of each course, you are asked to complete end of course surveys that, that give you another opportunity to provide feedback on all sorts of features within your classroom. And of course, you can also comment regarding the content clinics at that time as well. So I hope this has been informative and helpful to you, and I thank you, Professor Druitt, for your contribution, your information that you shared today, and I look forward to the future sessions that you will be leading with us starting Thursday next week.
Yep.
All right, thank you. And recordings will become available to everybody within 24 hours after the conclusion of each session. So information about where those will be located will be provided to you very soon. All right, thank you. Have a great day.